Hello and good afternoon, everyone. Welcome to the next session of AIIMS NAMS Navigate CME program. So this time we are with a very important topic, that is sarcoidosis. Earlier, it was considered to be one of the rare disease in India, but since there are more and more diagnostic tools with us, the awareness is increased. So now more and more cases of sarcoidosis are coming to notice. It may be pulmonary or extrapulmonary manifestations. So in the with time, we are noticing a number of cases of sarcoidosis. But the interesting thing, again, since we have a lot of cases related to pulmonary or extrapulmonary tuberculosis, so often the sarcoidosis cases are missed since we give priority to tuberculosis, and often they may be misdiagnosed due to some imaging similarities or maybe some other issues. So today, uh, it's the time now to get more clarity on the topic, and to proceed further, I would now request Professor Umesh Kapil sir for the welcome address. Sir is the Secretary of National Academy of Medical Sciences. Over to you, sir.
Thank you, Jaswant, for a brief introduction about the subject. Honestly speaking, sarcoidosis is not only important, it's a very important disease which is often overlooked by the physicians as well as the clinicians. We started this Navigate program so that all the postgraduates, junior residents, senior residents, and the young faculty members in different clinical specialties get benefited on important topics cutting across all the specialties to increase their knowledge. Now, the aim of the Navigate program essentially is to have the virtual increase in the knowledge of doctors at all the levels, be at the primary health center, secondary health center, that district hospital, tertiary care center, that is our medical colleges, and other similar institutions. Now, what we have done at the NAMS, we have chosen the very eminent scientists to deliver the lecture, and we have identified the topics which are cut across all the specialties. We have all the presentations which we are going to have are put on the virtual library of National Academy of Medical Sciences. We have till date about 92 lectures in the Navigate sessions. Their PowerPoint, their YouTube presentations, all are available on the NAMS website. Now, at present, I can see that 279 scientists have joined on the YouTube, and it's a good number, healthy number from different levels of healthcare. And I must thank Dr. Dhuria for giving us time and uh, efforts for undertaking this virtual Navigate program. My most sincere thanks to all the participants who have joined, and we'll have about 15 to 20 minutes discussions after the presentation so that the queries and the questions may be answered by our expert. With these few words, I'll close and over to you, Dr. Jaswant, for further uh, uh, proceedings. Thank you, Dr. Jaswant. Sorry, I am getting old. Sometimes I forget the name. Please
Yeah.
go ahead, Jaswant.
Thank you, sir. To continue with the session, I would now request the technical team to please show us a message from the President, National Academy of Medical Sciences, Dr. Digambar Behra.
My dear young colleagues, faculty, and officials of the National Academy of Medical Sciences, a very good afternoon to all of you. With immense pleasure, I invite you all to this program. National Academy of Medical Sciences, that is NAMS India, it was established on the 21st April of 1961 with the objectives of promoting the growth of medical sciences. It was inaugurated at New Delhi on 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The NAMS fosters and utilizes the academic excellence of health professionals in the country as its resource to promote excellence in medical education and skill development in the field of medicine and allied sciences. The Government of India has recognized the Academy as a nodal agency for promoting continuing medical education for medical and allied health professionals and is advising the Government of India on several matters of national health policy and planning. The best in the field of medicine are part of this umbrella organization, and who is who of medical science guide the norms. The National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. The aim of the National Virtual Postgraduate Medical CME is to facilitate the postgraduate students and young faculty members to increase their knowledge in the medical subjects, to navigate them to be more proficient in their profession and pass their NEET and PG examination to become better doctors, eminent biomedical scientists, teachers, and researchers. As a part of this responsibility, NAMS, in collaboration with the AIIMS New Delhi and 16 other AIIMS-like institutions of the country, has initiated this navigation program in the form of dialectical lectures and discussions. The program is regularly held every first Friday of the month at 3 p.m. The best and useful topics are carefully chosen, and the best teachers from various aims are picked up to prepare and give these lectures. I am sure you all will enjoy these talks and will like them and found them useful in your future lives. Thank you.
Thank you. So now I request the team for the message from Professor M. Srinivas. Sir is the director of All India Institute of Medical Sciences, New Delhi.
Namaskar. At the outset, I congratulate the team behind the NAMS-AIIMS Navigate CME program. Providing quality of education to our postgraduate students is one of the prime responsibilities of AIIMS. I know that our able faculty is leaving no stone unturned in achieving this mission. However, there always remains a scope for improvement. Through this unique initiative, there is an opportunity for our postgraduate students to learn from the experts in their field. This learning will go beyond the boundaries of department where our postgraduate students are working and will also bring in more flavor in their knowledge and at the same time ensure dissemination of uniform, high quality content all across the nation. Postgraduate students also form our primary workforce for providing patient care. This indeed is an important component of their training. We are aware that our postgraduate students devote a large component of their time for the patient care services and thus they have less time for self-study by the end of the day. The timing of this activity is therefore very carefully chosen. The sessions will be held late in the afternoon so that the beneficiaries do not have to make any extra effort for attending them. This by itself exudes the philosophy of a true teacher, a mentor that will handhold the children through the process of their active learning. As the sessions are online, which by its very design is a non-synchronous platform, it may seem that the delivery of the content will be one-sided, but enough measures have been planned and they are in place to make the activity as interactive as possible. The topic of the session will be shared with the students well in advance. This will allow them enough time to explore the subject and be better prepared to absorb the content. This design, therefore, also matches the concept and principles of adult learning. The program not only will help our postgraduate students in being better prepared for their examinations, but also will equip them with sufficient knowledge, understanding, and approach to be a better professional in their field. I wish this program all success. Thank you.
Thank you for the message. So now it's my turn to introduce the speaker for today. The eminent speaker for the topic is Dr. Sahjal Dhuria. He is additional professor in the Department of Pulmonary Medicine at PGIMER, Chandigarh. He has special interest in this area, ILD, sarcoidosis. He has numerous publications in his name and a huge H index of 56 and numerous awards in his name. You can see that for the PGI Research Day Award, he has been awarded a number of times. So with this brief introduction, now I would like to welcome Dr. Sahjal Dhuria. Over to you, sir.
Thank you so much, the president, the organizers, and the chairperson. And thank you for the kind introduction. I'm a pulmonologist, as has been told to the audience, and I have about 40 minutes to speak on sarcoidosis. As a pulmonologist, I'm gonna mostly focus on diagnosis and treatment of sarcoidosis. I'll try to stick to basic principles, try to explain certain things in more detail, and then I'll be very happy to take questions. So I'll be sharing my slides. Are the slides visible?
Yes, the slides are visible, sir.
Okay, so I'll start right away. So I'll be dealing during this lecture on certain topics or issues like what is sarcoidosis, when to suspect sarcoidosis, what is the diagnostic approach, what are the initial investigations, what screening tests for extrapulmonary involvement should be performed, when and how to get a tissue diagnosis, what are the major differential diagnoses and how to differentiate, do all patients require treatment, and if they, then when to treat and how to treat, and when and how to escalate treatment. So let's dwell upon what is actually sarcoidosis. So sarcoidosis by definition is a systemic granulomatous disorder of unknown etiology. So these three words or three terms are very important to understand the diagnostic pathway to this disease. So systemic, granulomatous, and of unknown etiology. When to suspect? I'm mostly going to focus on pulmonary sarcoidosis, being a pulmonologist myself, but I'm going to touch upon certain aspects of extrapulmonary sarcoid also during my lecture. So when to suspect pulmonary sarcoid? So a patient may come to you with a subacute onset of fever, cough, loss of appetite, or weight. This is a very typical presentation of patients who mostly present with lymph nodes alone or stage 1 sarcoid. So I call it a tuberculosis-like presentation. Another presentation is with chronic cough and dyspnea. So it may be chronic over months to years. Sometimes it's just a few months. And I call it an ILD-like presentation because most interstitial lung diseases will present with these two key symptoms. Other important symptoms pertaining to pulmonary sarcoid might be chest pain, which is a very important symptom in sarcoidosis. And fatigue. So sometimes it's only fatigue or fatigue associated with breathlessness and cough in such patients. What about extrapulmonary presentations? So skin is a very important organ which may be involved in about 15% cases. And the classic rash of skin sarcoid is lupus pernio, but it is extremely rare. More common are papules, nodules, and plaques. There might be arthritic presentations And that is called a Lofgren syndrome, especially when there is bilateral hilar lymphadenopathy, arthritis, ocular involvement, and fever. And there might be migratory polyarthritis along with erythema nodosa. There may be weakness, anorexia, nausea, constipation, and all these symptoms may point towards hypercalcemia, which will be picked up either when suspected or sometimes during a routine biochemistry screening of such patients with such symptoms. And on further investigation, sarcoidosis might be revealed to be the cause. Acute kidney injury usually occurs secondary to hypercalcemia, but sometimes a primary renal involvement by sarcoidosis is also there, but it is rare. Ocular symptoms are again one of the common manifestations of sarcoidosis, and it may be just red eyes or it may be blurring of vision. Sometimes an acute painless loss of vision might also occur. Sometimes there is some mild eye pain associated. Several times it is just asymptomatic hilar retinopathy, which is detected during screening by getting a chest radiograph or chest CT done for other purposes. Cardiac sarcoidosis occurs in about 5% of patients, and it may present with heart blocks, heart failure, arrhythmias, and a high index of suspicion is essential to really pick it up. Could you all please mute your mics?
Raviji, can you please, being host, can you please mute all the rest of the participants?
Neurosarcoidosis is another rarely occurring manifestation of extrapulmonary sarcoid. It occurs in only 5% of patients. Cranial neuropathy, especially facial nerve palsy, is one of the most important manifestations, but there may be brain and spinal cord involvement also. So the differential diagnosis of sarcoidosis in most of the circumstances is tuberculosis, especially with the first kind of presentation, other granulomatous disorders, and if it's an ILD-like presentation, then other interstitial lung diseases become important differentials, out of which hypersensitivity pneumonitis mimics closely to sarcoidosis. So the diagnostic approach, as I said, the secret lies in the definition of sarcoid, as it is a systemic and granulomatous disorder of unknown etiology. So the diagnostic approach should focus on these three key features, which is systemic, that is involvement of two or more organ systems. But sometimes it's just a single organ which is clearly involved clinically. There is systemic energy, another part of the systemic nature of this disease. Granulomatous, so you need demonstration of granulomas without significant necrosis in the affected organ. And unknown etiology, that is, one should be able to rule out known causes of granulomatous inflammation. So the first principle is systemic involvement. So as we looked at the various extrapulmonary organs which may be involved, lungs and lymph nodes might be involved in 90% of cases. Eye, skin, and joint involvement might occur 10 to 20% each. Liver, kidney, and heart may be involved again in 5% to 10% of cases each. Hypercalcemia and hypercalciuria occurs in 5 to 10% of cases, and then bone marrow involvement might occur in less than 5% of cases. So the initial investigations start with the chest radiograph, which might show classic manifestations of sarcoidosis. But who orders it depends on the presentation. So for example, any patient who comes with respiratory symptoms and goes to a pulmonologist or even a general physician, then the physician would almost always order a chest radiograph unless the manifestations are too mild or too short-lived. But with an extrapulmonary presentation, any kind of extrapulmonary presentation, it is very important to maintain a high index of suspicion for the particular specialist to be aware of manifestation of sarcoidosis. So if the physician is aware, then only he or she would suspect sarcoidosis and might order a chest imaging study. So on chest imaging, especially on a radiograph, There are various stages of sarcoidosis which were classified by scadding. So these are called scadding stages. So here in the first radiograph, you see these bulky hyla on both the sides. So it is bilateral hilar adenopathy, which is stage 1 sarcoidosis. The lung shadows appear more or less normal. In stage 2, there is bulky hyla all along with lung abnormalities in terms of reticular or nodular opacities in bilateral lungs. They are more common in the upper part and mid part of the lungs bilaterally. They are mostly symmetric. In stage 3, the hyla appear to be normal, so there are no significant mediastinal lymph nodes, but the lungs are still involved with reticulonodular opacities. Stage 4 sarcoidosis shows evidence of fibrosis happening, and that means there is some architectural distortion. There may be fibrotic bands, there may be fibrotic masses, and there may be a loss of lung volume. So, what are the other initial investigations for pulmonary sarcoid once you have got a chest radiograph done? So, in this day and age, a contrast enhanced CT along with a high resolution or thin section CT is a must to look at all the features of sarcoidosis and to rule out other kinds of differentials. A spirometry is the next initial investigation to quantify the lung function. A diffusion capacity of the lungs for carbon monoxide or DLCO is desirable if available, although certain guidelines mention it to be mandatory. But with this test being especially having problems with standardization, it is, I would say, desirable, but you can manage patients without DLCO also. Lung volumes are optional because they might not be needed routinely in all patients. But if you have a particular query, for example, if you want to really look at whether there is an obstructive or obstructive and a restrictive mixed defect in certain patients, lung volumes may be obtained. A tuberculin skin test is essential in our country, although Western guidelines do not recommend it. In our country, it is essential because a strongly positive tuberculin skin test done by a Mantoux method could be more in favor of tuberculosis, and in sarcoidosis, you would mostly find complete energy, that is a non-reactive TST. Serum ACE levels are not required in all cases because they are neither sensitive nor specific. If ACE levels are raised more than 2 or 2.5 times, then they might indicate the presence of sarcoid, but they may be present in other differential diagnosis also. On the CT, you might find lymph node enlargement. So you can see this aortic arch and superior vena cava as by the pointer. And this is a right lower paratracheal node. This is a region below the carina because the bronchi are divided. So it is just a cross section. And so this is the subcarinal node. So these two will be the most important nodes, and there'll be symmetric lymphadenopathy in sarcoid. But if you see a large asymmetric node, for example, this node with central hypodensities on a contrast enhanced CT scan, it may suggest necrosis within the node, and that is more suggestive of an infection, especially tuberculosis in our country. So in this particular case, I would not consider sarcoidosis as a differential. On the lung imaging, you would find nodules which are classically distributed along the perilymphatic paths or peribronchovascular. So this is the bronchovascular bundle. These are all bronchovascular bundles. And you can see fine nodularity on over these bronchovascular bundles. It is also called a perilymphatic distribution. So it is present along the septae or along the pleura. So this is a interlobular septum, and you can see septal beading sign, and there'll be pleural nodules like these in sarcoidosis. So this is just a close-up view showing the septal nodularity, the distribution of nodules along the bronchovascular septae or bronchovascular interstitium, which is almost classic of sarcoidosis, but you may also find these abnormalities in silicosis, in carcinomatous lymphangitis, and rarely in tuberculosis. And mostly in tuberculosis, you'll find centrilobular nodules. These are all perilymphatically distributed nodules. So Mantoux or a TST is still practically the most useful test for demonstrating energy in patients with sarcoidosis, as I explained earlier. It has an important role in the diagnostic differentiation between TB and sarcoid. So it is essential to do a TST in our country in all suspected patients of sarcoid. Only 10% of patients with sarcoidosis have a TST of more than 10 millimeters. And mostly in our experience, we have seen that it's mostly very close to 10 millimeters. It may be 10, 11, 12 millimeters, but strongly positive MANTO like a 25, 30 millimeter, it will be extremely, extremely rare with sarcoidosis. Interferon gamma release assays or IGRAs may be positive in 4 to 34% of patients, as found in a 2011 meta-analysis from our institute. And it will depend on different populations. So high TB burden countries like ours have an approximate IGRA positivity of 20 to 25% among sarcoidosis patients. So it clearly shows that MANTO and IGRA should be interpreted very differently in the case of sarcoid TB differentiation. So while a significantly positive MANTO will be highly unlikely with sarcoid, a positive IGRA just reflects latent TB presence even in patients with sarcoid. So a positive IGRA does not take you away from a diagnosis of sarcoid. Serum ACE levels, as I said, may be elevated in 75%, but due to poor sensitivity, insufficient specificity, with almost a 10% rate of false positive results, it may be useful only as a supportive kind of investigation to other clinical and radiologic and other laboratory details. It might be sometimes useful in diagnosing relapses or disease activity in certain situations. For example, somebody who starts with a very high ACE level, say 3 times raised, and with treatment, if it comes down and almost normalizes, and then if it rises again in that particular patient, it might suggest relapse. But as a whole, for the whole cohort of patients, it may be useful only in a few, not all. There are other conditions with increased ACE levels, for example, asbestosis, beryllium disease, fungal infections like coccidioidomycosis, sometimes in diabetes and Gaucher's disease, Hodgkin's disease, it might be raised. HP, rarely it may be raised, hypothyroidism, leprosy, lung cancer, PVC, and then granulomatous disorders like tuberculosis and in silicosis also it might be raised. So these sometimes are close differentials of sarcoid. For example, silicosis and TB are close differentials. So ACE will not help differentiate sarcoid from these two disorders. So it has limited diagnostic value. As I said, a lot of extrapulmonary organs may be involved with sarcoidosis. And the 2020 ATS statement on sarcoidosis diagnosis recommends certain investigations to screen for most of these extrapulmonary involvements. So I usually use this mnemonic ABCDEF to just remember what all investigations I need to order in the outpatient. So A is for alkaline phosphatase, which is to look at liver involvement, but I usually combine it with a GGTP, gamma glutamyl transpeptidase, which also is raised with a granulomatous hepatitis. Mostly we get a F done, which is a full LFT with GGTP and alkaline phosphatase. B is blood counts. C is for creatinine and calcium. And calcium should be assessed both in serum as well as in a 24-hour urine sample, because sometimes hypercalciuria is an often missed manifestation of sarcoidosis, which can lead to renal stones if it is persistent. So a urine screening of calcium excretion over 24 hours should not be missed. A vitamin D assessment is not essential, but if it is done, both 25-hydroxy and 125-hydroxy vitamin D assessment should be done, because 25-hydroxy vitamin D is the one which is present, but 125-hydroxy is the one secreted by sarcoidosis granulomas, and if it is raised, it leads to the suspicion that the sarcoidosis granulomas are producing this particular molecule, which might lead to hypercalcemia. If somebody with sarcoidosis, active sarcoidosis, who's not being treated with steroids, was found to have a low 25-hydroxy level, one must be very, very cautious in replacing vitamin D through supplementation, because it can easily lead to hypercalcemia in such patients. E is for eye, ECG, and echocardiography. So an eye exam is essential, as sometimes there may be a silent uveitis or silent ocular involvement going on, even without symptoms. So a screening is a must. Electrocardiogram and echocardiography are done to screen for cardiac sarcoidosis, although they are not very sensitive investigations, but obvious cardiac involvement will not be missed if these two are done. Then if you suspect cardiac sarcoidosis in particular cases, for example, somebody who is complaining of palpitations or pre-syncope or syncope-like episodes, then cardiac sarcoidosis should be suspected. Also, for the cardiologist, it is important to suspect cardiac sarcoid in any young patient. By young, it means a less than 60-year-old person who comes with unexplained heart failure, unexplained heart block, or unexplained arrhythmia. Their cardiac sarcoidosis should always be suspected and relevant investigation should be done. So one can start with a chest radiograph. If there is obvious thoracic involvement, it will be obvious on the chest radiograph. But if it is not there and cardiac sarcoidosis is strongly suspected, then the investigation of choice is a cardiac MRI. If cardiac MRI is not available, or for example, sometimes a patient would arrive to the emergency with a block or an arrhythmia and a intracardiac device will be put in immediately, then you can go ahead with a cardiac PET because sometimes these devices will not permit a regular MRI. So a cardiac PET can be obtained in those particular individuals. If suspected pulmonary hypertension is there, for example, if there is not much lung involvement, but there is an enlarged pulmonary artery or a loud P2 on physical examination, initial testing can be with a transthoracic echo. If TTE is suggestive, or even if it is not suggestive, but there is high index of suspicion, then right heart catheterization should be done on a case-to-case basis. So that is about suspecting a systemic kind of illness, which is the first principle or the first component of sarcoid definition. The second principle is demonstration of granulomatous inflammation. So when to biopsy? In the West, the Western guidelines, especially the 2020 guideline says that in typical presentations such as Lofgren's, where there is erythema nodosum, there is fever, there is ankle arthritis and bilateral hilar adenopathy, biopsy may be avoided. But our practice is to attempt tissue diagnosis in all because tuberculosis is a very significant differential in most cases of sarcoidosis in our country. So in most of our sarcoidosis patients, and nearly all of them who are willing and fit to undergo procedure will attempt to biopsy their lymph nodes and lungs so that we get a lot of tissue so that this differentiation between TB and sarcoidosis is made easier and easier. What to biopsy? So choose the most accessible site. If there are skin lesions, go ahead with skin biopsy. For example, if there are papules or nodules on the trunk, face, even plaques on the nodule, on the face, trunk, or extremities, then those lesions can be biopsied. But if there is erythema nodosum, so those are nodules on the shin, they should not be biopsied because they will not show you the classic granulomatous inflammation. Peripheral lymph nodes, if present, may be accessed using a fine needle aspiration or biopsy with a true cut needle. Then conjunctival sampling has been described, but we are not doing it, and we have not seen it done frequently in our practice. But the Western literature does describe conjunctival sampling with even no ocular involvement. But if above is not possible, then bronchoscopic biopsy is the best means, and it is the most frequently utilized modality for getting a tissue for finding granulomas in patients with sarcoidosis. So bronchoscopy can be done, and bronchoalveolar lavage may be the first procedure to be done during a bronchoscopy session. During which the lavage fluid which is obtained, it is a differential leukocyte count is done in that lavage, and a CD4 to CD8 ratio amongst the lymphocytes can be seen, but we are not utilizing this particular modality as it is not very specific or sensitive. Then the most utilized investigations are an endobronchial biopsy, that is the mucosa of the bronchus is sampled, a transbronchial lung biopsy, or a transbronchial needle aspiration. During a bronchoalveolar lavage, if you're doing it, then the most involved segment should be selected. If they are equally involved, then one of the segments or subsegment of the middle lobe or lingula on the left side in case of diffuse lung disease. And occasionally 2 or 3 different sites can be chosen to reach higher representation. So bronchoalveolar lavage is done by wedging the bronchoscope into the appropriate segment, injecting warm saline, mostly 120 ml. Then one has to wait for a few seconds and then apply gentle suction or aspirate with a 20 ml syringe and then collect return into a mucus trap. A recovery of at least 25% is acceptable. So this is the way a bronchoalveolar lavage is done. It is mostly for the specialist, but for the generalist, it is always good to basically understand how the procedure is done because it will give you a better awareness and a better decision making whenever you are referring patient to an interventionist. So you have just gone to the right upper lobe in the anterior segment, and you just wedge the bronchoscope there. That is, the bronchoscope cannot move ahead further because it is stuck there. The further segments are narrow, and then you just push in warm physiologic saline. So it just samples that part of the lung and obtains the cells which are there in the alveolar compartment and some part of the bronchial compartment. So if there are increased lymphocytes, it indicates certain disorders like sarcoidosis, hypersensitivity pneumonitis, and certain other ILDs. The bronchoalveolar lavage also helps you to rule out tuberculosis in cases where it is suspected. For example, if there are centrilobular nodules all over, you can get a BAL, look for acid-fast bacilli, and also send molecular tests like the Gene Expert or TrueNAT MTB to look for an evidence of mycobacterial DNA. So as I said, lymphocytosis is common in sarcoid. For CD4, CD8 ratio, the different cutoffs are there. Most uses 3.5, but sensitivity and specificity are average. So it's not a very good test with the kind of specialization that is involved with the CD4, CD8 assessment. Endobronchial biopsy is more straightforward, where bronchial mucosa, which might be abnormal in 30 to 40% of cases bronchoscopically, might be sampled with a forceps. So if there is abnormal mucosa, you might find granulomas in 50% or more cases. But even if the mucosa is endoscopically normal, it might still give you granulomatous inflammation in 30% or more cases. So it is a good modality and it can be easily be done. I'm showing this as an example of bronchial biopsy. This is a bronchial biopsy taken from an endobronchial growth, not a patient from sarcoid, but it just demonstrates how a bronchial biopsy can be done. Then there is the transbronchial lung biopsy, which is done by piercing the bronchiolar wall and going to the most peripheral part of the lung parenchyma and then pinching that part with a regular biopsy forceps. And remember, while we do the TBLB, we cannot really see the lung parenchyma. Our bronchoscope is wedged at a very proximal area inside one of the subsegmental bronchi. And only the forceps proceeds, and without any particular visual aid, we are doing this kind of sampling. Sometimes it may be aided with a fluoroscopy, but not direct vision. So this is the kind of forceps. It just is a schematic which shows the forceps goes in and it goes till the peripheral part of the lung parenchyma, and then the part of the tissue is pinched. So if you have a very focal abnormality, then you must remember that a TBLB, which is not guided by a visual kind of examination, will not give you the diagnosis. It is done only where there is a diffuse involvement with nodules. There are other modalities for localized involvement, but a blind or conventional transbronchial lung biopsy is not the modality for localized nodules. So as you see, our bronchoscope is stuck here in this particular segment, but the forceps has gone inside, and we just withdraw the forceps, open it, and then push it again, and then we close it, and then we take it out with the lung tissue. And it is frequently succeeded by some bit of bleeding, which stops with just the bronchoscope being wedged there or with some cold saline or adrenaline instillation. Then there is the TBNA, or transbronchial needle aspiration, where a needle is introduced through the wall of the bronchus and it goes to the lymph node which is lying across the wall of the bronchus. So in this particular case, this is the carina, and we have inserted this needle into the subcarinal space without any particular visual aid, and we are shaking it so that, and there is suction applied on the outer part of this needle, so that any material from the lymph node can be sucked in, just like a peripheral node FNAC. So this is again a blind procedure where we are just localizing the lymph node only by our knowledge of the anatomy based on the CT scan, and there is no particular visual aid. But now for the past about 15 years, we have this particular scope, which is called the endobronchial ultrasound scope or endosonography. So here, if you put the scope in, you can really visualize the lymph node in ultrasound vision, and then this needle can go in under vision into the lymph node, and it is safer, and it is high yielding in terms of the lymph node material which can be obtained. So again, you can see this carina, and we had just put our scope against the carina, and you could see this lymph node which we are measuring with the particular calipers, and then we are now putting the needle inside, and you can see the needle in ultrasound vision within this lymph node, and we are just shaking the needle with suction applied on the other end to get a sample of the lymph node aspirate. So it is similar to the other FNA I showed, conventional TBNA, but it has a ultrasound guided facility. Then you have another kind of biopsy which is done with a cryoprobe. So the routine transbronchial lung biopsy is done with a forceps, but TBLC is done with the cryoprobe, wherein the cryoprobe can be inserted deep into the lung parenchyma. It is frozen for 3 to 4 seconds, and then it is taken out. And compared to a conventional forceps biopsy, this is a very large biopsy taken from a cryoprobe, where differentiation between TB and sarcoid is made much, much easier. As you can see, these large areas of lung parenchyma and these granulomas, which are showing a central area of necrosis. So this particular case had tuberculosis, which could have been missed had we not had this large sample. So what is the average yield of all the procedures that I showed in diagnosing sarcoid? BAL, as I said, has a poor sensitivity and specificity. It is useful to exclude TB if you are really suspecting it. Endobronchial biopsy, an average yield of 40%. Conventional TBNA, that is the blind FNA, 60%. The blind TBLB, 70%. The EBUS guided needle aspiration, 80%. And if you combine all these procedures, EBUS, TBNA, EBB, and TBLB, then it gives you a 93% yield. So our practice is to do all the three procedures if there are lymph nodes and lung involvement to get this high yield. So the third principle is to exclude known cases of granulomatous inflammation. And this is a list of a huge number of differentials which can give rise to granulomas and lymph nodes or other organs like lungs, skin, liver, bone marrow, and other biopsy sites. You can just take a pic of this, and I can proceed because these are too many differentials. But in our country, I would again tell you that TB is the first and most important differential. It is there at the top of the list in all the different organs. So the most important is to avoid pitfalls. So never consider yourself, and we always try to avoid this pitfall that we are the big bosses and we know what is sarcoid, what is TB. So there is always a difference between judgment and verdict. So all these cases which I'm showing here now, there may be certain features which point towards sarcoid or TB. For example, this is asymmetric disease, more suggestive of TB. This is more symmetric disease, more suggestive of sarcoidosis. Here there is some segmental collapse. But in all these cases, it is very difficult to really say for sure that whether it is sarcoid or TB. So again, a few CT images which show these kind of peribronchial nodules or peribronchial consolidation, these ill-defined nodules. So these are all manifestations which are shared by TB and sarcoidosis apart from their classic manifestations. And you can refer to this particular article published from our center way back, and it gives you a very good differentiation points between the two. And I'll not go through the entire list, but you could just note down the reference, and you could go through this entire table. Most of the things I've already dealt with during my presentation. I'll point out a few more, like the use of certain molecular tests like a PCR, or now we have this automated PCR, which is called the cartridge-based or chip-based nucleic acid amplification test. These are very useful while we are trying to differentiate between the two disorders. So suppose in pathology also there are features which point towards one or the other disorder. If there are numerous granulomas, they favor sarcoid. If there are few or no granulomas, it is again sarcoid, more towards TB. Loosely organized granulomas, those with necrosis, those with a stain or culture positivity for microbes, obviously point towards diagnosis other than sarcoid. As I said, molecular tests like Expert MTB or Expert MTB Ultra or even the TrueNAT might be useful, as Expert MTB in this particular publication from our institute showed about a 50% sensitivity in picking up tuberculosis. A low sensitivity, but the specificity is quite high. So the positive predictive value or a positive likelihood ratio is quite high. So it's a very useful test, even if it has a lower sensitivity. So I'll just go through this particular flowchart and then I'll delve a bit on the treatment. The diagnostic part was more important for the generalist. Treatment, I'll try to be brief and try to cover it in the remaining time. So if there's a clinical presentation which is highly supportive of sarcoid, for example, Lofgren syndrome, lupus pernio, as I said, it's a characteristic skin rash, Harefoot syndrome or bilateral hilar adenopathy without any symptoms, then it can be called a probable sarcoidosis without even doing a biopsy. But this is a Western guideline. In our country, we'll still do a tissue diagnosis in all these cases. If it is consistent with sarcoid clinical presentation, but there are other manifestations, that biopsy is recommended even by the Western guidelines. And finally, you go ahead with looking for granulomatous inflammation, looking for a systemic nature of the disease, and then ruling out different causes of granulomatous disorders. And finally, you make a diagnosis of sarcoidosis. Most experts say that sarcoidosis is always a probable diagnosis because it is very difficult to really definitively rule out all other causes of granulomas, especially in our country with high TB burden. Diagnosis of definite sarcoid is mostly made on follow-up once the patient either recovers without treatment or recovers with some kind of anti-inflammatory treatment. So treatment, as I said, the etiopath. So the treatment basically principles rely on the etiopathogenesis of sarcoid. So with sarcoid, there is an unknown antigen which is coming from the environment mostly, or there is some kind of molecular mimicry, and then there is a granulomatous response mounted towards that antigen. So the natural response of the body by this granuloma is to clear the antigen. And if the antigen is cleared, the granulomas will resolve by themselves. But if there is a situation of danger, for example, an organ is threatened or a life is threatened, or there is impaired quality of life, then you tend to treat the patients with steroids or other immunosuppressive agents. In that case, because you are going against the natural mechanisms of the body, sometimes the antigen might persist because now you are not allowing the granulomas to take care of the antigen. And this is a hypothesis which says that with over-treatment of sarcoid, there may be antigen persistence and the sarcoid may become chronic. So this is just a proposed kind of theory which is not proven, although in some cases we do believe it might be happening. In other cases where steroids are essential to save life or improve quality of life, it is always better to go ahead with the treatment. So do all patients require treatment? We do not treat all our patients with sarcoidosis because stage 1 sarcoid remits in a majority without treatment. Lofgren's occurs in up to 30% patients and remits in 80% within 2 years without steroid treatment. Therapy with glucocorticoids has several adverse effects. As you know, a lot of weight gain, obesity, hyperglycemia, raised hypertension, cataracts, osteoporosis, and several other adverse effects. If there's a cumulative dose of prednisolone which exceeds 500 milligram, it is associated with poorer quality of life and a lot of side effects. No treatment has been conclusively shown to modify long-term outcomes. So we should not treat all patients unless they really require immunosuppressive treatment. So if we get 100 patients with sarcoidosis at our center, 50 will not require treatment at diagnosis and 50 would require treatment at diagnosis. Amongst those who didn't require treatment at diagnosis, 40 to 45 will achieve spontaneous remission, but 5 to 10 will require treatment over the ensuing 2 years. Those who require treatment at diagnosis, 25 will be chronic and they'll still be on treatment at 2 years, and 25 will achieve long-term remission. So 5 to 15 will develop chronic respiratory impairment. It may be up to 20% of such patients who become chronic and require immunosuppressive treatment on a longer term. So when to treat? As I said, if there is potential danger of a fatal outcome or permanent disability, an organ is threatened or life is threatened, or if there is unacceptable loss of quality of life. A fatal outcome occurs in the short term, mostly in cardiac sarcoidosis and hardly any other. Sometimes severe hypercalcemia, if it is untreated, may lead to renal failure, may be fatal, but rarely. Pulmonary sarcoid is generally not fatal in the short term, but if it is chronic, progressive, leads to fibrotic sarcoid, then it may be fatal over a longer duration of time, over several years. So, need for treatment for pulmonary sarcoid is when there is considerable dyspnea affecting the patient's lifestyle. So, there's a lot of excessive cough, not responding to antitussives, or if there is significant fatigue, myalgia, and arthralgia, or if the organ is threatened or there is organ dysfunction. For example, forced vital capacity is reduced to say less than 70%, a DLCO is reduced, or if there is a declining lung function in terms of a drop in FVC or DLCO compared to baseline. Common extrapulmonary indications would be a multi-system disorder, especially if vital organs like the heart is threatened, if there is CNS or peripheral nerves which are involved. Ocular sarcoid will always require treatment, either topical or oral therapy. Cutaneous, as I said, if they have papules, plaques, they might recover with just topical therapy or require systemic treatment, especially lupus pernio will require systemic treatment. Hypercalcemia should be managed with hydration and mostly requires steroids. Hepatic sarcoid, if it is only a bit of biochemical elevation of liver parameters, we might observe the patient, not treat in the first go. But if there is a significantly elevated alkaline phosphatase (GGTP), and if you do a fibroscan, you see that the liver parenchyma is altered, then you might decide to treat with immunosuppressive therapy. Cardiac sarcoid, if symptomatic, should always be treated, whether it is arrhythmias, whether it is heart block, whether it is heart failure. Neurologic, as I said, cranial nerve palsy is most common. The fifth nerve palsy should be treated with immunosuppressants. Brain and spinal involvement, again, very difficult to differentiate from differentials like TB and others, but it should always be treated with immunosuppressive therapy. Similarly, granulomatous nephritis, which is rare, mostly kidney involvement is secondary to hypercalcemia. But if it is there, it should be treated with immunosuppressants. How to treat? So the goal of initial treatment is to control symptoms, improve and stabilize organ function. Especially in case of pulmonary sarcoid, you need to stabilize or improve lung function as shown by spirometry, DLCO, and even lung volumes if required. Radiologic improvement, that is the chest X-ray should improve with treatment, at least stabilize, but a complete resolution might not be seen in all cases. For example, some patients would already have developed some amount of lung fibrosis, so a complete resolution might not be possible. And it is very important to minimize or avoid adverse effects, as sometimes it is not sarcoidosis which causes like severe or serious manifestations or poor quality of life. Rather, it is the medication and its adverse effects which lead to such problems. So agents to treat. The first line agent is glucocorticoids. We use prednisolone as the most common glucocorticoid in our practice. Second line agents, again, certain immunosuppressive agents like methotrexate, azathioprine, leflunomide, and mycophenolate mofetil. Out of these, methotrexate is the preferred one. Second choice is azathioprine. Third line agents, hardly used in our country, very rarely used, biologics like infliximab and adalimumab, which are anti-TNF alpha agents. These are to be used very cautiously because they increase the risk of tuberculosis significantly. So in our country, they are used very cautiously in only cases where the first and second line treatment has failed or is not tolerated. Then antifibrotics. If there is progressive fibrosis in patients with pulmonary sarcoid, then antifibrotics like nintedanib might be used. And certain agents are used off-label and in rare cases, if others are not working, like cyclophosphamide, rituximab, tofacitinib, tocilizumab. These are rarely used. I have hardly ever used tofacitinib or tocilizumab. So glucocorticoid doses in earlier studies from the 70s, 80s, the recommendations or the suggestions were to use a very high dose, like a 1 milligram per kg dose or a 60 milligram dose. And for that too for 1 to 2 years, and it led to several adverse effects. And over time, people have realized that these such doses and such durations are not always required. And these guidelines, the British Thoracic Society guideline and the European Respiratory Society guidelines, have come in after a big lag of 20 years since the last guideline, and they clearly prefer a lower dosing of prednisolone, like a 20 to 40 milligram per day, as told by the PTS guideline, but the ERS guideline says that it should be only 20 milligram per day of prednisolone equivalent as the initial treatment. And if the indication is only loss of quality of life, for example, if there is unmanageable cough, then lower doses, maybe a 10 milligram or even a 5 milligram dose could be used. And it could be a negotiated dose with the patient, generally lower doses, so that the adverse effects are minimized and the effect on the quality of life can be maximized. So we performed this particular trial and published it in the European Respiratory Journal in 2023, wherein we looked at a high initial dose, 40 milligram versus a low initial dose, 20 milligram prednisolone for treating sarcoidosis. It was called the SARCOD trial. And it has made a paradigm shift in terms of how we initially treat sarcoidosis. So in this particular trial, we enrolled about 86 subjects, and to one arm, 43 patients, we gave a 40 milligram initial prednisolone dose and tapered it over 6 months. In the other arm, it was 20 milligram to start with. The entire protocol is written in the footnote. So 20 milligram for 8 weeks, followed by 15 for 8 weeks, then 10 for 4 weeks, and 5 for 4 weeks, followed by tapering. So in both the cases, we had a very similar relapse rate over 18 months. So we stopped treatment after 6 months. And over the next 12 months, there was a high relapse rate of about 45%, but it was equal in both the arms. We carefully selected a very short duration of steroids in this particular case, that is only 6 months, while most guidelines say that therapy might be anywhere from 6 to 24 months once you have decided to treat. This particular trial clearly showed that you need not opt for a 40 milligram initial dose. A 20 milligram initial prednisolone dose will give you similar outcomes in terms of relapse rates, in terms of FVC change, health status, quality of life, and treatment adverse effects. Treatment adverse effects were numerically higher in 40 milligram dose, although statistically any individual adverse effect did not reach statistical significance. So once you start with a 20 milligram dose, when and how to step up or switch treatment. So when is there indication for second line treatment? When over a long term, that is over a period of 6 months, if you are not able to get your glucocorticoid or prednisolone dose to less than 10 milligram, then it is better that you add a second line treatment, because a 10 milligram or more dose of prednisolone over a long term, that is beyond 6 months, has a significant rate of adverse events. If there is refractory sarcoid, if the inflammation is so much that it is not responding to a short intense burst of steroids, then you might opt for certain other agents or combine steroids with non-steroid agents. If there is fibrotic sarcoid, which is refractory to anti-inflammatory treatment, then you might go to antifibrotics. So second line treatment, anti-inflammatory treatment, as I said, methotrexate, azathioprine are the preferred drugs. If these cannot be used, then leflunomide and mycophenolate mofetil can be used. Methotrexate, larger experience, documented improvement in pulmonary function and radiographic changes in certain observational studies, and it has a good steroid sparing effect. So the recommended dose is 10 to 15 milligram per week. It may be up to 25 milligram per week, but we usually started with 15 milligram per week of methotrexate. And we routinely give folate supplementation as a 5 milligram per week dose on the day after the methotrexate dosing. So there are various ways of supplementing folate. We use this 5 milligram per day on the following day protocol. Azathioprine leads to equivalent improvement in lung function as methotrexate. It is better tolerated in patients with kidney and liver dysfunction, but it might have a higher rate of infections than methotrexate. The dosing is 2 milligram per kg per day. So for an average 60 to 70 kilogram patient, so the dose may be anywhere from 100 to 150 milligram per day. Beyond methotrexate and azathioprine, as I said, if you are not able to use these two drugs, leflunomide at a dose of 10 to 20 milligram per day or mycophenolate at a dose of 2 to 3 grams per day is a good alternative, although data are much lesser for these two agents than methotrexate and azathioprine. Adverse effects, as you might be aware, if you're using these drugs, GI intolerance is an adverse effect with all of these, but methotrexate has a special problem with liver dysfunction. Azathioprine might lead to hematological toxicity more than other agents. Leflunomide is associated with neuropathy, and mycophenolate mofetil might cause diarrhea. All of these are immunosuppressive agents, so they might be associated with the risk of infections. So as I said, that if we have 100 patients, about 50 would require treatment initially, but 60 overall, 60 to 70 will require treatment at any point of time. And mostly these patients will recover with methotrexate and low-dose prednisolone. Only 5% patients or so would require anything beyond prednisolone and methotrexate in our setting. The third line treatment, as I said, is required if there is failure of second line treatment or if there is continued disease despite second line treatment. So in that case, infliximab, which is a chimeric antibody against TNF alpha, might be used. It is frequently used in other rheumatologic disorders. In sarcoidosis, there is a special problem here because sometimes TB and sarcoid differentiation is really challenging. So it should never be used as a first-line agent. Only in patients with chronic sarcoid in whom you have used other agents, other immunosuppressive agents, you have carefully excluded TB as contributing to the manifestations. And once you have excluded latent TB or treated latent TB, then only you must go to these agents, infliximab or adalimumab, which is a subcutaneous humanized antibody against TNF alpha, and it can be given as weekly subcutaneous doses at home for the patient. Other agents are pulse high-dose steroids, rarely used, but it is used in, say, life-threatening cardiac disease. Somebody is having a block or arrhythmias or heart failure, which is progressing rapidly. Vision-threatening eye disease and neurosarcoidosis also. So neurologists sometimes use pulse high-dose steroids for 3 to 5 days of IV methylprednisolone. Cyclophosphamide hardly ever used, but cardiac and neurosarcoid are the only indications. Extrapulmonary involvement, as I said, if there is mild disease, it could be settled with topical treatment for the skin and the eye. But HCQS has a role here, hydroxychloroquine, for mild skin or eye disease and sometimes even hypercalcemia. Then apremilast, which I have never used, but it has been described in the literature. For lupus pernio, infliximab has been described because sometimes it does not respond well to steroids. It's quite a disfiguring skin condition. So infliximab has been used for lupus pernio. Non-immunosuppressive therapy for fatigue, you might use some stimulants like armodafinil. Pulmonary hypertension, pulmonary vasodilators are used only if it is a primary involvement of the pulmonary vessels. If it is secondary to lung disease, pulmonary vasodilators may not help. Progressive fibrotic disease, as I said, antifibrotic treatment with nintedanib can be given. Non-pharmacological treatments include immunization, very important. Any chronic lung disease patient, you must immunize or vaccinate with influenza and pneumococcal vaccines, the COVID-19 vaccine. And if there is a lot of immunosuppression being given, varicella vaccination is also required. Pulmonary rehabilitation, oxygen supplementation, and lung transplantation are required for advanced disease. I'm not going to go into details of these, but these are required in advanced patients with hypoxemia, pulmonary hypertension, and progressive fibrotic sarcoid. So I'll conclude here with the messages that one must know common presentations of sarcoidosis, be it pulmonary or extrapulmonary, with special attention to extrapulmonary features, especially for the internist or for other specialists who must not miss manifestations of cardiac sarcoid, neurosarcoid, manifestations of hypercalcemia with its attendant, with excluding other causes of hypercalcemia and then suspecting sarcoid in such patients. One must attempt tissue diagnosis in all cases in high TB endemic regions because TB is a very close differential. Other differentials are interstitial lung diseases. As I said, if there is cough and dyspnea, the primary differential is interstitial lung disease. A negative tuberculin skin test is sensitive for sarcoid. So 90% of sarcoid patients will have a negative MANTO test. 10% might still have a positive test, but IGRA will not help you differentiate TB from sarcoid, active TB from sarcoid. One must combine different bronchoscopic biopsy modalities like TBNA, endobronchial and transbronchial lung biopsies for tissue diagnosis, as it gives a more than 90% yield, gives you a lot of tissue, to look for necrosis, to look for AFB, to look for molecular tests like TB DNA using molecular tests, and the screening for extrapulmonary involvement, as I noted with the mnemonic ABCDEF, should be done in all cases of sarcoidosis. Treatment is initiated only if there is organ dysfunction, there is life-threatening disease, or impaired quality of life. Initiated mostly with glucocorticoids. There has been a recent trial which says methotrexate might be used as a monotherapy for initial treatment, but it still needs more experience before we start recommending methotrexate as the sole agent for initial therapy. So it is mostly a second-line agent along with azathioprine as another alternative. Need to go beyond glucocorticoids, and methotrexate rises only in 5 to 10%. So these are the two primary drugs which should be able to take care of your sarcoid patients mostly. TNF-alpha inhibitors in refractory disease with a low quality evidence, and non-inflammatory therapy for associated conditions or advanced disease. Thank you so much.
Okay, thank you, sir, for the wonderful presentation. Am I audible?
Yes, yes.
Sir, that was an excellent presentation, and we could learn, I think, a lot. So there is one question already for you from Dr. Gopi Sethi. Yeah. So, he's asking about HCQs mainly. That mainly regarding hypercalcemia in sarcoidosis.
So the literature does,
yeah.
The literature does say that hypercalcemia may be treated with hydroxychloroquine. We have had a few cases where we tried this drug as a sole therapy, but it doesn't work so well in my experience. It is better that you start with a lot of hydration for such patients. Mostly we'll admit such a patient in a ward and give them saline hydration with or without diuretics. And then we'll use glucocorticoids or steroid therapy once we have a tissue diagnosis, or once we have at least obtained tissue for further histopathological diagnosis. Sometimes other calcium reducing agents might be used, like bisphosphonates or calcitriol or other such agents. But mostly it's steroids and hydration which will do the trick over a longer term. If we want to maintain, then low dose steroid or methotrexate are good agents. Hydroxychloroquine, I would say that if there is very mildly raised calcium and there are no other manifestations requiring treatment, then it might be used.
Thank you, sir. I request the participants to be fast, or to type the questions, or they can just unmute themselves and ask the questions. So if anyone wants to unmute themselves, they can just raise their hand. We'll unmute them. If I see the list, so if anyone can raise their hand. The topic was very simple. That was simplified, sir. Like various mnemonics were used, A, B, C, D, E, F, G, H, and also like you showed the videos which were very helpful, sir, and that was a unique presentation, I would say, sir, because one have both audio, visual, and like the procedural memory. So that's fantastic. Thank you, sir. I think there are no further questions since it was very well told, sir. Thank you very much, sir. So
Thanks.
now I request, it's time to request Professor Ajay Kumar Sood, sir, for the word of thanks. Sir is the Deputy Secretary of National Academy of Medical Sciences. Over to you, sir.
Thank you so much, Dr. Jaswant. It is indeed my great privilege to thank the distinguished speaker for this evening, Dr. Sajal Dhuria, sir, for covering this complex topic of sarcoidosis in a very simple and comprehensive way, as you said. And I'm sure that all the participants, especially our PG students, they have greatly benefited from the practical tips he has given for diagnosis and treatment. So thank you so much, Dr. Sajal, and we look forward for your support in the future also. I will also like to thank all the participants, especially our faculty members from various institutions as well as the PG student for being with us. And as again, I would like to repeat that for faculty member, this is your own program. Please come forward, and if you can suggest topics and also come forward for taking the session. For next year, tentatively, we had decided to cover the various topics from the discipline of pediatrics, gynae, and general surgery. And some of the topics could also be taken from dental sciences, which are related to the oral health. So if any one of you is interested, you can please share your contact detail and also the topic which you would like to take in next year. And as you know, these are on 2 days, first and third Friday from 3 p.m. to 5 p.m. So any time which is suited to you, we are planning to make the detailed schedule for next year. So that will be great. Another information for senior faculty member is that our fellowships are open till 31st of December. So you are requested to apply for NAMS fellowship for next year, that is 2026. And if you have your colleagues in other countries, they can also apply for international fellowship. So you can communicate to them. All these forms are available online on the National Academy of Medical Sciences website. For those of medical fraternity members who are having degree in DM and MCH, and they have 3 publications, they can also apply for associate fellowship. And if you have MD, and after 5 years, you can enroll as members of the academy. And the fresh MD can immediately enroll for associate membership. So these are a lot of fellowships and membership are for almost all categories, starting from the MD pass to the MCH and senior faculty members. Even the DNB candidates who have passed the DNB, they can also apply for our membership. So all these details we have shared on the chat box, and also these are available on the National Academy website. Another information for PG student is that we have in collaboration with ICMR, we have a biostatistical helpline for postgraduate and young faculty members. So you can register on this online portal, and you can fix your slot and discuss with the expert both from the National Academy as well from the ICMR regarding the thesis related issues, especially the sample size and other things. Another interesting information is for PG students who are technology savvy and our faculty members. NAMS, in collaboration with IIIT Hyderabad, has initiated a 12 weeks online program on artificial intelligence for health professionals. Now the third batch is currently being registered. The last date is 15th of December. And again, we have shared this on the chat box. So for the PG student, there is a special concession of 50% for the registration fee, So if you're a PG student, your registration fee will be reduced by 50%. So please take benefit from these facilities of the academy, which we have started with other institutions. Another information is for the next session, which we have on 19th of December. There again, we are going to cover a very interesting topic on approach to a patient with peripheral neuropathy, and very senior faculty member from PGI Chandigarh, Dr. Manoj Goyal is going to take that session. So if you have any question related to this topic, you please share with us, and we'll request the speaker to cover these during the session. So I will take this opportunity also to thank Dr. Jaswant, who has been helping us from the very beginning for moderating the session so well. And we look forward for support in future also. Thank you so much for your valuable time and support to the academy. Here in the academy, our IT team headed by Mr. Ravi and Mr. Shivam, they have done a lot of homework writing to you and also ensuring that this is telecast on the Zoom as well as on YouTube. And all these recording, as our secretary sir said, are available on the NAMS website. And we have also circulated in the chat box the link for these sessions. So you can just go through any number of time if you are interested. So once again, I thank you all for being with us. Thank you so much. Namaskar. Over to you, Dr. Jaswant.
Thank you, sir. So with your permission,